Hello. We really appreciate you being here in this afternoon. I know that some of you have been since the morning, so this is an achievement. Congratulations that you're still here. My name is Luba Botcheva, and I'm the Director of Research and Strategic Projects at the Mental Health Association of San Francisco. And I will be moderating this panel with this incredibly talented gentleman. The title of our panel is Tools, Talent, and Technique, and I hope that this talent will give you the techniques and tools so that you can succeed in the area of behavioral health. We really would love to have a good discussion about the field and how we can be helpful to address the issues or questions that you might have about applying health and technology in the area of behavioral health. So I will be moderating, focusing on certain topics, and at the end we will give the opportunity for interactive discussion because this is a relatively new field and there are a lot of promise of new developments which I hope that we can touch upon. So I would give the opportunity of these talented gentlemen to introduce themselves and we'll continue from there. So Kristian.
Thank you, Luba. Hi everyone, my name is Kristian Ranta. I'm the founder and CEO of Meru Health, and we are an online medical clinic treating depression, burnout, and anxiety with remote licensed therapists and some data analytics and individualizing care for people with different kind of backgrounds, demographics, and symptomology and stuff like that. And yeah, strong believers in sort of like an online medical clinic model where you have remote clinicians helping people to go through a lot of sort of like self-help exercises and a lot of learning of new tools and stuff like that. So that's what we do. And then maybe kind of a good point to mention that unfortunately, like I personally, like why I started, why I'm doing this, what I'm doing, is that I founded the company in 2015, and I had lost my brother roughly 12 years ago to suicide. And that's the reason why I wanted to, this is my second company in healthcare, so that's the reason why I wanted to now, second time entrepreneur, start working on something that can help other people like my brother, Peter, and you know, hopefully be able to contribute in a meaningful way in the next 10 years or 20 years or whatever it's going to be. Thanks for having me.
Hi, my name is Andrew Chacko. I guess this turns on appropriately when we're about to speak, so perfect. And I'm super excited to be here. Thank you for hosting us and moderating this, and to the audience for being here. One of the things I found, to speak to what Kristian was saying, is a lot of people in the healthcare space, healthcare startup space, a lot of us end up here out of, it's different than being in any other startup space. There's often personal motivation, and that makes it much more near and dear to our hearts that there's personal incentive to come out and do something good for the world. So it's an amazing space to be in, and there's a lot of work to do. So that said, a little bit about my background. I came through the product design program, graduate program, here at Stanford after 12 years in the Navy as an officer, working in leadership and teamwork. And after working a little bit as a designer, teaching design, I decided I wanted to become a physician to really take design into the healthcare space. So I'm currently a practicing psychiatrist, but do a lot of work in the innovation and healthcare space, teaching design thinking, and also consulting around like what the opportunities are for where we can make inroads in healthcare and mental health care specifically.
I love hearing what each of you guys do and how you got here. My name is Mike Byer. I'm from Washington, D.C., and I'm here more as a representative of a collaborative called M3. M3 is a group of people who are like-minded in looking at mental health, saying, are people singly with one diagnosis, one set of problems, or people have several symptoms which are causing them to have mental stressors or a high symptom burden? This is a 30-year effort, I think, that we include two of the last directors of Byer, Psych, and NIMH. My preference is math, and together as a group, we sort of said, how can math, how can what we know as a group change the view of mental health for this single diagnosis view? That we had an assessment that was published in the Annals of Family Medicine, and what it enabled was mental health to sort of be destigmatized and spoken about like other chronic conditions. So if I have high diabetes, I have a high sugar level, I have hemoglobin A1C, I may have a cholesterol problem. But mental health has always been sort of like a squishy adjective from somebody you really didn't know. You go to your doctor, you'd say that you have a stomach ache, that wouldn't even really be your mental health problem. Maybe you'd get called depressed. That in our research, which we just went over a couple million people, it shows it lined up with the Kessler report. More people have anxiety and anxiety symptoms than just depression. So if you were going to look at mental health, you'd want to look at anxiety, you'd want to look at depression, bipolar, PTSD, impairment, all things which in normal would happen. If I went and saw Andrew as my psychiatrist, you would see, am I impaired? How are my relations? What are your symptoms? Not many people have 45 minutes to go see Andrew, and Andrew doesn't have that many 45-minute times to go see Kristian's work. It enables a person at home to get a view of their mental health symptoms. It enables a person to get an intervention pathway to help themselves and not be left alone. So we're happy to be part of this tech dialogue. Although we wear the science hat, which is a little dweeby to it, we think science is an important consideration to health tech, and welcome including it with this panel.
Thank you. And I've been thinking about this last chair, and I was thinking who we can put there. And I really want, as a person that comes from the Mental Health Association of San Francisco, to say that this would be the individual with the mental health and other challenges. And I really would hope that we would not forget this when we have this conversation. So it's kind of a good opportunity that we have this empty chair, and this is our consumer and our client. And I hope that we all would remember this during this panel.
I have a real problem. You see her.
Yeah, and we'll see how you address that. So, so speaking about that, I really want to make a short overview of the way that I've seen the field evolve in the last couple of years, and in the area of mental health and behavioral health. We had a conference, Mental Health 3.0 in San Francisco, and we invited a lot of people to talk about that. And at this point of time, 2 years ago, we thought that it was the Wild West, that everybody was trying to get into the field, but there weren't so many regulations. People were creating apps and exploring the opportunities around tech, but it wasn't quite sure whether the interventions are evidence-based, whether they focus on the specific problems of individuals. And what I saw and observed, and very pleased, what I see is that I think that the field evolved in many ways. I think that people started to understand that, first of all, mental health is not different as health. It's just part of our health. And we can look at it as a continuum that starts with normal health and illness, but also has the opportunity to advance and to get to a higher performance, where we look at people that are using mental health technology so that they can become better in the performance in their field. So I think that this became a very interesting opportunity and development. The second one is that I think that there are much more evidence-based practices that are entering the field, and I'm really very happy that the gentlemen that represent the talent in the field are really using data and tools so that we know that what we are offering is effective. And then the third one I think that is happening is we are just on the crisp of using this artificial intelligence and big data that would allow us really not only to transform the existing interventions, but to create new interventions because of the power of the data and the technology. And this is where I hope that we will go. So I would love to hear a little bit from you. How do you, what do you see as the major developments in the field at the present? And
well, yeah, maybe like a few words from me first. So I think that like one thing which when I came from diabetes and then I kind of started taking a deep dive in mental health and wanted to build my next company in mental health. One thing which I realized, being an outsider, it's sometimes easy to see things that you don't anymore see when you're like have been in some industry for a while. One thing which I realized was that there's like almost no data at all in mental health care. Meaning that like people's symptoms are not being tracked and that there's like no real follow-up, and like a lot of patients are actually treated at primary care for like depression as an example, like 80% or something like that, and then like there's no official follow-up in many places, and there's like no collection of their symptoms or nothing like that. It feels like totally like, and of course there are like better clinics and all that, but on a general level, it's like seems to be pretty underdeveloped in many ways. So that was a huge surprise for me as a newcomer and coming from diabetes, where basically like everything is measured and all that. And then kind of over time learned to understand in mental health that it's maybe because of like some of the background on like why it is like this, so that people don't there's of course self-report scales that are now being used more and more, and that's kind of a good development in my opinion, but there's like the background from psychology, and like I think that there's a lot of that attitude in a way even still around, that where people think that it's not possible to measure these things, that it doesn't make sense to collect data because the mind is something so magical that it cannot be measured, which I totally think is just BS. So it's kind of like that. If we start, sorry. Yes, exactly. Thanks. So I think that it's kind of important to just like break the barriers and like really start measuring things and start looking at data and analyzing data. So what I actually personally believe, I know that there's a lot of AI and a lot of kind of cool stuff happening and blockchain and everything, but I think that actually the lowest hanging fruit in mental health and even in many other fields of digital health is just data analytics. And just like, let's first collect data, analyze data, and learn to individualize and, more towards like meeting people where they are and understanding their conditions better. So just even like as a first step, I'm I know this might be controversial in some ways, but I'm advocating like just let's do even basic data analysis first. And I think that's starting to happen, which is, I think, super encouraging. So that's like what I wanted to say in the beginning.
So I have some thoughts on this. Who has the next 6 hours free? So a few thoughts, and I want to sort of set the stage for what I think around, and I came to discover this as I became a psychiatrist and going through residency, and I had stumbled into psychiatry because I knew I wanted to do innovation, and this was something that I thought I could do in conjunction with that, have a clinical presence. And I started to realize that as clinicians, we don't often cure someone entirely, regardless of in what capacity their function or what capacity their illness or condition is, right? Someone with diabetes that's well treated is not the same as someone without diabetes entirely, right? So there's always a difference, and the idea. So what we're actually trying to do is try to increase people's quality of life, to make it as good as possible. Like, as a clinician, that's what I strive to do. What defines someone's quality of life, and how do I make it as good as possible? And one of the key determinants of someone's quality of life is their psyche, is their mental makeup, right? How do they see themselves? How do they see their condition? And so someone's mental health is so fundamental to the way their health plays out to begin with. How they respond to anything, and to understand that and proceed with addressing that is super important. So now when it comes to like what are our interventions, and I'm a huge technophile, so that's probably one of the reasons I ended up on this panel, but I also think there's a role for technology. And I think there's just this sort of dichotomy between convenience and connection. And we're starting to meld these two ideas. Technology, for me, represents convenience, right? How do I get my groceries delivered more conveniently? How can I connect with my mother in Idaho more conveniently, right? Or how can I, get my dog washed? I'll be using an app, whatever it is, right? So all this is about convenience. people are about connection. And at the end of the day, when it comes to the quality of our life, and certainly to the quality of mental health care, it hinges so much on connection. And so how do we put the right technology in place to enable that connection? How do we make our clinicians more effective at connecting with their patients? How do we make our patients more effective at connecting with the other people around them, with their network, with the other resources they have, right? So looking with that lens at, okay, now where are the technological gaps that we can start to fill? So, and I love this analogy about Gary Kasparov and how, does everyone know who Gary Kasparov is? This audience should definitely know. So he was the chess grandmaster that was beaten by IBM's supercomputer, and we thought that was the death of human intelligence, right? And he hosted another chess championship. And it turned out that a handful of very talented chess players, not grandmasters, and but by no means like entry level, armed with decent computers, not supercomputers, together beat out the chess grandmasters as well as the supercomputers. So what is this synthesis between and this cooperation between humans and AI? And what's that right mix? So how do we use technology to be able to make me a better clinician or help the patient better get their needs met? And I think that is one of the things that, looking forward, we're only sort of just barely beginning these brushstrokes into this space. It's a pretty complicated space. So I think looking at that and moving forward with that direction in mind is going to be super helpful.
Thank you. Michael?
So this is, you asked about the consumer, like what are the big changes that are happening?
Yeah.
And I'd like to speak to our friend here.
Here we go.
Here, yeah. So
excuse
me.
Very nice.
Yeah.
Nice outfit and stuff like that, yeah.
That we operate a anonymous free website that anybody can go to, and 40, 50,000 people do every month. So that gives us a lot of insight, not into really AI, but really a chance for machine learning before you even get to the AI level. And on top of that, we do this thing on iTunes, so we can see people's comments, which are anonymous. They can say whatever they want, and you start reading into what people are saying. And people are saying, look, I know I'm not just this, I know I'm not just that. I'm a mixture of a couple different things. And I think as the consumer, or a person, gets more comfortable that mental health is not a stigmatizing event, but is something that they can talk about, is something that they don't have to take medicine for, but they could take a strengthening or resiliency building effort for, is something that they could be monitored to see if they're not progressing or if they need supplemental care with medicine to help achieve their goals, is that it's too big of one word that Josh Gordon, who's the head of NIMH, he just came out and said, everything that happens to the brain is a physical. Everything that happens to mental health is a physical result. And then we had a little debate about that, because there's reaction to my brain. If I was in a war zone, I had PTSD, there would be a change to my brain. But was that change as an advent of an event that happened, almost like a social determinant? I was in a bad place and something happened. So I think the more people are allowed to communicate their range of efforts, and the more care is oriented towards providing relief for what's bothering that person, that mental health will become more like a normal chronic disease that will be managed like my cholesterol or my diabetes. And I think that's going to be a real plus, because we come from primary care, and primary care's first job is to provide relief. And being able to speak about it at this granular level lets it be personal. You were sort of a little reluctant about precision meds for behavioral health, because if you were all my doctor and you said, which treatment do you want, and you gave me my choice of picking treatments, I'd have a 70-some% chance of success. Where if you picked the treatment for me, it'd be less than 50%. Yeah. So, I think precision's neat, but personal still deserves a seat. And I think that this is what's going to happen as we go forward with individuals using their health savings account dollars to start taking ownership of what's acknowledged as an issue. Of, if so many people have this over life, then everybody's potentially at risk.
Thank you. And actually, it seems like that the theme here is really connectivity and convenience. And I think that the connection is also empowering the individual who would be the person that has the mental health, shifting the model that the individual will be in charge of what they need. Not only the clinician will be the person that would tell them, which was the previous medical model in which we assume that a person with mental health conditions is not empowered enough to make decisions about themselves. So I think that this is important.
So
shift.
I had a thought that I wanted to address. First of all, I'm used to a very interactive discussion with my audiences, and I wanted to just check in and see. I threw a few analogies at you, and if there's any questions around that, I totally welcome them either now or please connect with me afterwards. But for the most part,
time for questions.
Yeah. I just wanted to see if it, for the most part, made sense. Yeah, all right. Okay, great. Thanks for validating me up here. So one of the things that I think is really interesting with mental health and that separates it from primary care and something that's really difficult because we all sort of battle this idea of the stigma of mental health, right? So if I've got Crohn's disease or a stomach condition, or a GI problem or something like that, I don't necessarily think that reflects poorly on me as a person, right? But if I'm depressed or anxious, now people start thinking like, I should be able to think my way out of this, right? This is just a fault of my thinking. And one of the issues is that there isn't a separation between your brain, your mind, and if you believe in it, your soul, right? And because there isn't, am I having bad thoughts because there's a tumor sitting on my frontal lobe? Or is it because, like, I'm a bad person? Or is it because, this is who I am? Like, so that sort of continuum, it's harder to answer. People don't necessarily feel as much of it's a personal responsibility if, for example, they have gout, even though they might feel they should be able to manage it better. It's kind of a condition they can separate their self-identity from. But in mental health, so many of my patients come to me and feel like I should be able to get out of this on my own. This is my problem. And even so, I've worked principally with the VA and have a lot of veteran patients who have florid PTSD, and many of them think, I should not be affected by this in the way it's affecting me. And so the first part is to kind of step back and say, like, give them permission to feel that they are not their disease. These thoughts are not them. But that stigma is going to be really huge in making mental health care kind of more accessible, right? But I don't know what the solution is to that.
But that's an interesting point. Like there's like this, like you said, like there's this separation, but eventually everything is connected. So and either way, like if you have like a PTSD problem, it is definitely manifested in your body as well. It is manifested in your brain. It is manifested in maybe other parts of your body as well. So it is actually physical, even though if you might not know it, it is already physical. And if you're suffering from it, and also like people with like long-term depression, they have like there's like a lot of science showing that they have like very different brain kind of functionality or functioning than people who don't have depression. So it is actually physical, and we should just like start recognizing it as such. But then on the other hand, also remembering that a lot of physical diseases or somatic diseases are also mental. Like Michael, you had a really interesting point just back there about the data on the heart attacks, was it? Like, and that like the biggest predictor of heart attacks was actually the mental condition. So it's like super interesting. Like, and this is like I think which is needed also, the dialogue and the discussion around both ways, like how somatic disease is connected to your mental states and how mental states are actually manifested in your physiology.
And I think the technology can really help with working with the self-stigma and the stigma. What you're referring to is the stigma that we have in the society around mental illness, but a lot of people that have the illness would develop this self-stigma where they would blame themselves and stuff like that. I think that when you have a good technology where you can have empowering thoughts about it, or individually you can kind of create your treatment and feel and track progress, this might help you in a way, I guess.
I want to talk to our friend again.
Here we go. I knew
I've been a big fan, not that I'm in San Francisco, of what Facebook can do. So I'm really sorry if this is an incorrect statement for political correctness, but the community in Facebook and how it reaches out and encourages other people in the anxiety room, in the veterans room for PTSD, in the mania room for bipolar veterans that are considering suicide. The peer-to-peer part, I think, is going to be a gigantic contributor. The empathy part, and I think the interventions, these web-based interventions that I can take at home at 11 o'clock in my pajamas on my little mobile device is sort of like a peer-to-peer intervention. It's like a friend. It's somebody that I can bring in. I can bring in your app. I can bring in the ideas to build strengthening. So I think when you look at what's happening right now is a huge understanding and an empathy to build it in. So I think people are going to be less in their doctor's offices. But there's a big silo. Most of this is stuck in the payer world, where a lot of times we're talking about people on Medicaid and things like that who would benefit from these apps. They won't see these for 5 years. Right now, it's all clogged up, I think, in the payer world. So one thing we'd like to see is how we can work towards extending these to less fortunate situations, because these care extenders are really valuable.
I want to check also with the audience and knowing who is usually the audience at this conference. How many of you are interested in building startup in the mental health space? Okay. And how many of you are on the clinical side or? Good mixture, because you can mix together and create the tools and techniques, and here is the talent. But that's why I want in the remainder of the time also to talk a little bit, because you all are entrepreneurs in a different way. You built your startup, and I think that it would be very useful for the audience to hear how did you make it, what are the challenges, what are the payers that you see, so that you can sustain your model. So if you can all talk a little bit about that, I think that the audience would appreciate it.
Yeah, no, that's a good point. So, this is my second startup, and building a startup in the medical field or in like digital health or medical devices and stuff like that, it's definitely it's quite challenging, and it takes quite a long time also. So you definitely need persistence and so like stamina. But I think that it's kind of hard to maybe exactly to just crack everything in a short pitch about how to build companies. But I think that one thing I've learned over time, which is maybe like the single most important lesson that I've learned through like a lot of heartache and pain, was that you should definitely really consider the team that you start working with. So the co-founders and the team that you are going to found your company with and that you're going to work with is extremely important. And even more like what is important in there. Personally, what I learned through my kind of failures and my heartaches and pain that I mentioned was that it's extremely important to find people with value alignment. So when you're seeking for a co-founder or you're kind of like hiring your first people into your team, like values and that they're aligned, that people are doing these things for the same reasons than you are, and that they believe in the same reasons and the same kind of basis for building what you're building, and that is extremely important. And in my first company, I had a lot of misalignment with the values in the core team, and eventually that didn't kill the company, but almost killed the company, and we had so much trouble because of all these things. So I think that's at least one thing that I've learned, and would encourage everyone who's wanting to build a startup or is building a startup to pay extra attention on finding the right people. And I'm not saying that I still do fail still even today, and it's only my second company, so I'm probably going to be better after a few other companies. But still, it's something that at least I'm now became very conscious of, and I'm really trying personally in my own company to make sure that we have the team is like aligned and mission driven, and at least in my company that's an important point, not necessarily with everyone's company, but just like few cents on that.
That's a great answer. I'm sitting there listening to what you're saying and not thinking about what I was going to, but I started thinking about I don't know if people have heard of Simon Sinek and Start With Why. It's really about it's about exactly what you're saying. It's like, what is your why, and why are you doing what you do? And if you're really clear on that, then it's easier for people to either decide that they align with you and want to be committed to what you're doing, or that they're kind of off, they need to move in a different direction. So that's a beautiful statement, or a beautiful thing to ponder. One of the things that I was thinking around what I'm building is there's an African proverb that says, give a man a fish, you feed him for a day, teach him to fish, and this is a gender-neutral man, by the way. Then you feed him for a lifetime, right? So, and the idea is by teaching the design process and teaching that to the people that are out there working with the problems and trying to come up with solutions, that we can then get an army of people that are all kind of working together, answering the right problems. And that, I think, there's a really critical statement there. It's first, I break down the design process into 3 legs. One is first really understanding and defining the problem. And that's so important, I can't even stress it enough, right? Like really kind of scaling back. And if we have like a few minutes, I'd love to tell the story that started here at Stanford. So in 2007, has everyone heard about the Embrace infant warmer? Oh, we're down to 5 minutes. Okay, I'm going to tell you.
No, we have enough time. It is for questions. Yeah,
all right.
Go ahead.
So in 2007, these 5 graduate students came together at the D School, and they came from different walks of life, from the MBA program, from electrical engineering, and wherever else, and they came together for a class in extreme affordability or extreme sustainability. And they were presented with the problem of premature infant mortality. And as they started solving that problem, they thought, okay, well, there's 20 million infants born prematurely every year around the world. 1 million die within the first 24 hours by some estimates. 4 million within the first 4 weeks. And the leading cause of that death is hypothermia. And our current first world solution is, these incubators, and these incubators run about $20,000, so arguably expensive. So they started working on how do we make cheaper incubators, and they're working on this and working on this. And fortunately, one of the team members, this guy Linus, ended up taking a trip to Nepal during the course. And while he was there, he's walking through the hospital, and he noticed there's all these unused incubators lying around. And as he's looking at the incubators, he asked the doctor, and he said, what's the deal? How, not quite in those words probably, but how do you have a problem with premature infant mortality and all these incubators are lying around unused? And the doctor looked at him and said, the infants aren't dying here in the hospital. They're dying in the villages. And it was like something went off. We're kind of working on something wrong. Something's wrong with what we're doing. So they went back to the drawing board, and they started thinking about, okay, what's the real problem they were trying to address? Any thoughts? Electricity is a problem, right? Temperature, as in the temperature of the baby, right? The real problem is the baby wasn't staying warm. An incubator was just a solution. Thank you, by the way, for people that answer back. The baby wasn't staying warm, and the incubator was just a solution. And maybe in these cases, it needed a different solution. So then they ended up making this basically a sleeping bag out of the space-age material. And what they would do is slip in the back. They would take this paraffin wax sleeve that you could heat in a pot of boiling water, and it would get to the right temperature, and you could slip it in the back of this sleeping bag, and it would keep the baby warm at the right temperature for up to 5 hours, at which point you just replace the sleeve, because they realized that an incubator is designed for a clinician and it needs electricity, right? And what did that new mother, who they decided the user they were designing for, didn't have? A clinician or reliable electricity. So that wasn't a great solution. So when they really understood the problem that the baby wasn't staying warm, it opened up a whole host of solutions that they could start targeting. So the opportunity ahead of us is to really recognize what the problem is. And it wasn't for, up until that point, millions of dollars and tons of companies were spent sending all these incubators, incubator after incubator after incubator, to these third world countries trying to solve the problem. And it just took, what I love about this is these 5 were neither designers nor were they healthcare experts. They just took time to really understand the problem in front of them. And so there's room for all of us to be involved in that.
Thank you so much. And maybe some of your thoughts to hear, and then we can open to the audience too. Yeah.
First, I want to comment about the story Andrew told and how the joy of the random walk, unplanned events, are impacting mental health for hugely. There was a story about ketamine that's been out. I'm sure everybody's heard about this. That ketamine was a drug used for people for pain relief, I think it was. And then one of the veterans that were getting it said, "Oh, my nightmares have gone away." And the doctor said, "That's nice. I'm really not I'm not in charge of your mental health. I'm in charge of your pain management." And the veteran went to his veterans group. He says, "Oh, you guys got to try this. This is the beginning of a health research study." And now one of the biggest hopes, I guess, for treatment management depression, ketamine, right? A random event that was found without planning, but through the use of data to help make observations was there. But I want to answer your question about, gee, if I was an entrepreneur, again, how would I approach this venture to make it less painful, more pleasurable? And my one-sentence reaction is I wouldn't get infatuated with big hospitals. I would look in my backyard. I would not spend my money on travel. I would develop personal relationships with clinicians that you can gain feedback from, and people that you align with as a team, collaborators, because it's very expensive, this hobby, and to be able to iterate in an agile way to make an observation, make a change, observation, change, is really, and to include the clinician, patients, people, in this whole process is a way, I think, of minimizing aggravation, maximizing participation, and hopefully product improvement, because it's all built around outcomes, which is the 50-cent word.
Thank you. I really want, it goes so fast because it's such a talented group. So let me open for questions. Yeah.
So most mental health, behavioral health. Hi, my name is Arthur Keller with Psychoanalytics, and most behavioral health, mental health conditions are untreated. And most treatment for behavioral health conditions, if it occurs in primary care, where the clinicians don't really know how to diagnose, they don't really know how to treat. So the question is, how do you really deal with the issue in primary care of getting these people the help they need, and they're not trained to do that. So how do you get them the help they need?
I have a thought. And one of the things I do when I teach residents, and I think it's something that really needs to be addressed, is for those going through primary care training, unless they're in family practice, like internal medicine, for example, they do rotations in cardiology and wherever else, pulmonology and critical care. What they don't do is rotations with psychiatry. And I think that would be a beginning to at least get them to start learning and understanding, so that when the patient presents that has some mental health issues, that they're not going back to their psychiatry rotation in medical school and their what they learned as a second-year medical student. And so the training is a really big, I think, big part of that issue or solution.
Hi, I'm Motoko. I am a psychotherapist and CPA, so I love data, numbers, why I love talking to people. I have a question for, I think, everyone here. So there is a couple of information. I wonder if these informations have been utilized. One is ACE study. So ACE study means adverse childhood experience studies done by Kaiser Permanente or a lot of institutions. What is said is like when a kid has multiple trauma, we already know this particular kid will have a lot of health issues as well as shortened life expectancies. So that's one number. And the other one is multi-generational trauma. So if your grandfather or grandmother went through a starvation, highly likely you are exposed to have obesity because your genetic expression tells you store the food in your body. So I am hoping those two data sets have been somehow reflected into mental health or, where, I don't know how to say, wearables or measuring tools so that like we can account what happened in the past to the present moment health issues.
Yeah, and I know that, Michael, I think that you were referring to PTSD as a big factor and predictor. Yeah.
Yeah, I think so. I'm here. We all hear more and more about the ACE study, which is really great. That like there's evidence now that confirms what we already know. Like trauma affects people, and this is actually going to go to what you were saying very appropriately. In the West, I'm going to say we separate the body and the brain and the mind out because we need to carve things out to make it easier to study. But there really isn't that much of a separation, as much of a separation as we make it out to be. There's this great neuroscientist named Daniel Wolpert, and he, if you haven't seen his TED Talk, I totally recommend it. And he says, you have a brain for one reason. It's because you move, right? Non-living things don't have a brain. Living things that don't move don't have a brain. Once a creature starts to move with any sort of purpose, as opposed to like chemotaxis or something, it develops a nervous system to control that movement. So your brain and your physical being and your mind are intimately connected. To think that they're not connected is a disservice. So yes, trauma figures into how your body stores all that. And there are somatic, sequelae for psychological conditions and psychological condition or sequelae for somatic conditions, right? So we know this, and I think that you bring up a really interesting point, and we need to kind of keep like being made aware of it. I don't think it's perfectly done quite yet, but yeah.
Yeah, that's definitely super important. I mean, like, I guess that the Western medicine is only now starting to realize that this can sort of like through generations these things can be inherited, and they can like stay in your sort of like some kind of a. Maybe it's DNA, maybe it's something else. I don't think we even yet totally understand all that. But it's extremely interesting, and it's definitely super relevant. So we should study this, and we're getting bigger and bigger data sets available to us, and better machine learning tools and stuff like that. So I think it's now more than ever it's possible to study these things and understand correlations and stuff like that. So.
All right, it's time for our favorite topic at M3. It's all about kids. The earlier you can reach into someone to start gaining these type of insights and to start providing coping skills to manage, the safer children are as they become adolescents. We've been following kids from 11 up through 18. We did 18 up before. And there's a lot of people would say, gee, kids are different from adults, but they're not that different. There's a real big similarity. And these stressors that they have, they bring out other stressors. So I think that your question about following people over time, determining which people are at greater risk, providing them skills, all is something that would happen for any other condition. For if I was heavy, my parents were heavy, somebody would say, oh, look, you're heavy, you want to take care of that. So I think your points are super well taken, and I do want to say that anybody interested in researching kids and mental health, please call us.
Okay, we have five more minutes. Are there any other questions? Yeah.
Thank you. This has been a really interesting panel. My name is Simran, and I wanted to ask a conversation I've had with a few other people here, and a question on my mind is, how do you address the challenge of reaching the people who need help the most, so who need the mental health? So we've talked about all these great tools and resources we're testing out, but how do you actually get to the right people?
Well, yeah, maybe I can start maybe with that. So that's a huge challenge. So like I don't think that anyone really has like one single silver bullet answer, but what we're trying to do is to try to make our treatment very available and sort of like confidential and easy to access and quick to access, so that when you need help, the help is there for you, and then you get to help quickly. But it's still that's one of the biggest challenges, and I'm not sure that even we can like as a sole provider kind of address that problem. I think we will need to rethink the whole healthcare system in many ways, and provide more kind of reach people where they are, maybe through social media, maybe through of course the internet, I guess, but like that's definitely a really important question, and definitely hard to answer at this point.
I think one of the big things that is going to play into that is education, right? But education that actually registers with people. So I think there's huge benefit when celebrities come out and say, "I'm suffering with this, and they'll, they can go through what the symptoms are or what they experience, and all of a sudden, so oftentimes people that are suffering with depression, anxiety, bipolar, whatever they're suffering with, they don't even know they're suffering with it, one, and if they are suffering with it, they often think it's just them and there's something wrong with them, and like wrong with them as a person, as opposed to like, wrong with some chemical that's misfiring in their brain or something else. But to normalize that experience and they can then say, oh, I relate to what X, Y, and Z or whatever person is going through, and all of a sudden they realize, and they're given a metric by which to measure their experience and feel like I'm not alone in this, then we can start, I believe people start accessing care more when they can kind of identify what they're going through, and they feel like they're not, there's less shame around coming forward about it. So.
Yeah, actually, contact-based strategies have been shown as the most effective way to address stigma. In general, contact-based. So when people come and tell their stories, or people can identify with others, this is the best way to...
I want to put a plug in for what you do, the community behavioral health centers.
Yeah.
Because if it wasn't for the community behavioral health centers, nobody that's less fortunate would be getting any type of decent care in the world. And to me, the most compassionate, most person-centric, most measurement-based care, most monitoring is really happening in these less fortunate settings. So I think there's a level up from the less fortunate settings, which is really the big hole of people being missed. Yeah. Because when I go to the FQHCs, it's a blessing to see how people are treated as individuals or complex cases and receive real care. So I want to thank you for the work you're doing.
Thank you. Any more questions? Yeah.
So I'm Amy Lee, founder of Dance for Healing. Started after my stage 4 cancer. Focus on trying to bridging art in healthcare and make behavior change a little bit easier and fun. So a lot of our work is based on published medical research, how the power of creative arts therapy, both in mental and physical health. One of the quick data would be improve quality of life for cancer patients by 50%, and there's many more. So I'm kind of curious. So oftentimes when I speak at conferences, if I asking how many people like music, everybody raise their hand. How many people like dance? Maybe half or 60% or whatever. But if I do one of these medical research data, it's like 0 hands in the entire room. And I'm very happy to see this panel focus on behavior change. And I'm kind of curious, are you guys aware of these medical research data behind creative arts therapy? Are you implementing any of these creative arts therapy in your current practice?
Yeah, that's a good question. So we're not, but I'm kind of super interested in like learning of new modalities, and we're currently like cognitive behavioral therapy, mindfulness, and then behavioral activation therapy. Like these elements we mix into our care. But I'd love to talk more. That sounds interesting.
I'm a drama therapist as a background also, so I truly believe in the power of expressive art. So it's another thing how we can combine it with technology, but yeah. I think that we're coming to a close. This went so fast. Maybe just closing remarks from all of you. I think that I just want to, it's almost like a bombshell, maybe what I would say, but I want you also to be, for us to be aware about the impact of technology on mental health, because more and more research is coming out that shows that using a lot of technology, especially among adolescents, have a negative effect on mental health. So I hope that we will be in the future also addressing this important issue. But I want to hear from you what are your hopes for the next year or so in the work that you're doing?
Well, I think like a general hope is that I think it's empowering for everyone to for people to speak openly about these things. So that's why I'm always sharing my personal story about my brother, and I also kind of like appreciate that you're also thinking about that perspective, that it's really important to just like connect with other human beings and show people and share your stories that it's totally normal to have, depression or anxiety or these symptoms. And every one of us almost has some of these symptoms, or in every one of our families or close circles, we have these things. So it's nothing to be ashamed of. And I think that's something that is kind of a really important step towards healing as a community in this field.
So if I think to echo some of what you said, and for me, it's not an admonition, but more kind of a plea that as we start developing the new technologies, if you can hold a metric against it, that is this bringing us closer together, or is this kind of helping people become more isolated, right? Is your app, is your technology allowing someone to stay more in their house? And it just struck me the other day that we could conceivably never leave our house, like get all our meals delivered, everything taken care of without interacting with another human being. And so the question comes up, is this the world and this the life we want to create? And I would argue that actually starts robbing us of the real essence of what creates a great quality of life. And so are you helping us get closer together? And I would say that's ultimately the goal.
Michael?
I think that this is a lot of fun. I want to share one last piece of data. Is when we asked in a regression analysis, what symptom is most predictive of someone not having a mental health condition? And that it was not a symptom, but the response was impairment with family or friends. What you were just talking about was relationships and people. So I want to share that when we look at things, people matter the most. And if you have anybody that has a problem, be extra compassionate, because if somebody's opening up to you, it's because they need to. So thank you.
Thank you.
Thank you all.
Thank you.